In 1991, St. Raymond's underwent its first restructuring. Financial difficulties and declining birth rates reduced the demand for pediatric inpatient services. The hospital consolidated departments and transferred assets. Behavioral programs were expensive. Ward C was not profitable. The foundation absorbed Ward C's operating costs. The hospital allowed it to continue. During restructuring, 7 children were transferred into private placements. Transfers were classified as discharges to home care. Home care discharges did not require state notification. No adoption forms were filed. No custody hearings were held. No birth certificates were modified. The children disappeared from public record. Not all staff approved, some protested. One nurse resigned. In her resignation letter, dated 1991, she wrote, "We are not preparing these children for the world. We are preparing them for rooms." She did not specify which rooms. By 1993, Ward C no longer appeared on internal maps. The wing was repurposed as storage. Most staff assumed the program ended. It did not. The remote care division continued operations through private placements until 1995. Children were not returned. Children were not re-evaluated. Children were not monitored. Once placed, they remained placed. The foundation collected reports from guardians. Reports did not measure mental health, they measured silence. Several reports used identical language. Subject remains compliant. No resistance observed. No incidents. Compliance replaced progress. Program success was not measured by outcomes. It was measured by absence. In 1995, foundation funding ceased. Ward C was officially dissolved the following year. St. Raymond's rebranded as a community health facility. Behavioral programs were discontinued. Remote placements were not annulled. Children remained in private. St. Raymond's closed to the public in 1997. The building was sold to a private developer. Most records were stored off-site. Some were destroyed. The remote care division was never mentioned in the closing statements. When investigators attempted to trace the children years later, they discovered an unexpected problem. Several of the subjects had no legal identity. They did not appear in school records. They did not appear in census data. They did not appear in adoption registries. Some did not appear in birth registries. It was unclear whether they had been born in hospitals or surrendered without documentation. One administrator described the period in an interview years later. Hospitals did not create missing children. They processed them. The state did not investigate. There was no legal framework to do so. No crime had been reported. No complaints were filed. No children were listed as missing. Children without paperwork cannot be returned. Children without paperwork cannot be found. When the program ended, no one asked what happened to the children. They became adults without histories. Some received identification through employment programs, some did not. Some entered state care as adults. Some disappeared into private contracts. The foundation did not comment. The hospital did not respond. The state did not interfere. Investigators identified 12 subjects in total. 8 were transferred. 4 remained. Only 6 corresponded to missing. Children reports from the same period. Half the children in the program were never reported missing at all. Families did not lose them. They surrendered them. The hospital did not hide them. It transferred them. The state did not search for them. It was never notified when the program ended. The children did not return to their families. They did not return to institutions. They did not return to the state. They entered adulthood through private channels. The remote care division did not dissolve. It changed form. Some of the children became contractors. Some became clerical assistants. Some entered custodial services. Some entered remote programs. Compliance made them employable. The foundation called the program a success. One internal memo summarized the outcome. Subjects demonstrated sustained compliance in non-institutional environments. The memo did not address identity. It did not address autonomy. It did not address consent. It addressed compliance. Ward C did not treat children. It produced compliant adults. Documentation from the period describes environmental conditioning as reduction of stimuli to promote adaptive behaviors. Adaptive behaviors included sitting, eating, sleeping, using restrooms, following instructions, remaining still, avoiding outbursts. Accepting restraints compliance was not defined as recovery. It was defined as the absence of resistance. In 1987, Ward C entered Phase 3. Phase 3 introduced the concept of transfer. The Foundation believed long-term compliance could not be achieved in institutional settings. Institutions communicated artificial authority. Children in hospitals obeyed because hospitals demanded obedience. This did not prove compliance, it proved context to determine whether compliance would persist outside the hospital. The Foundation introduced the Remote Care Division. The Remote Care Division coordinated placements between Ward C and external environments. These environments included private homes, rented apartments, and supervised care units in Providence and surrounding areas. On paper, these were classified as home care placements. Families did not adopt children, they received stipends. Guardians were not foster parents, they were participants in a program. Records show that 8 children were transferred to Remote Care Division placements between 1987 and 1995. 4 children remained in Ward C until the program ended. Parents often believed they were surrendering children into long-term care. Many were told their children would receive treatment unavailable elsewhere. In reality, the hospital did not categorize these cases as medical treatment, it categorized them as behavioral research. A former staff member described the period this way: hospitals don't run research programs. Foundations do. The hospital is just where the children were kept. Families rarely followed up. Some believed their children were being treated. Some were relieved. Some disappeared from the process. Court records from the period list many cases as voluntary surrender. Voluntary surrender did not obligate the state to track the child. Once surrendered, the child became the responsibility of the institution, not the parent and not the state. Ward C was not unique. Dozens of behavioral programs operated in the United States during the same era. Some focused on medication, some focused on restraint, some focused on aversion. Therapy. Ward C focused on compliance. Compliance eliminated conflict. Compliance simplified care. Compliance reduced costs. Compliance made children manageable. The Foundation did not claim it could cure behavioral disorders. It claimed it could make them irrelevant. The Remote Care Division was not widely advertised within the hospital. Most staff were unaware of its existence. Placement decisions were made by a small committee that included 1 administrator, 1 physician, and 2 representatives of the Foundation. Minutes of committee meetings do not exist. Decisions were recorded as memos. One memo from 1989 reads, Phase 3 subjects performing above baseline eligible for private placement in other states. External environments improve compliance beyond observation. Compliance did not refer to learning phase. 3 subjects did not attend school. They did not visit public spaces. They did not interact with other children. Compliance meant silence, stillness, and obedience. The Foundation believed silence was evidence of adaptation. Staff believed silence was evidence of control. Parents believed silence was evidence of progress. None of these beliefs were tested. Ward C did not operate without oversight. It operated without interest. Regulatory agencies focused on billing, not behavior. Insurance covered inpatient, psychiatric care for minors. No agency monitored compliance research. Private funding did not require disclosure. The state assumed that children were being treated. The hospital assumed the children were being studied. The Foundation assumed the children were being improved. No one assumed the children would grow up. St. Raymond's Pediatric Hospital did not close it. Changed ownership. Most institutions that fail are remembered through headlines and lawsuits. St. Raymond's was not that kind of institution. It ended quietly, through restructuring, asset transfers, and rebranding when it disappeared from public maps in the late 1990s. Most residents assumed it had simply moved. They did not ask where the children went. They did not ask where the staff went. They did not ask what happened to Ward C. To understand the program, we must begin with the hospital itself. St. Raymond's opened in 1958 as a regional pediatric facility. It served Providence and the surrounding areas of Rhode Island, drawing patients from lower income neighborhoods and rural communities. Most families used it as a safety net. Few could afford private pediatric care in Boston. During its first decades, the hospital focused on common childhood illnesses, respiratory infections, congenital disorders, burns, and injuries. This changed in the mid-1970s, when cases of behavioral disorders increased nationwide. Schools and courts struggled to manage children who did not respond to standard discipline or medication. Parents, overwhelmed and without alternatives, sought referrals to psychiatric facilities. St. Raymond's adapted it, expanded its pediatric psychiatric unit. The unit occupied a narrow wing behind the main hospital. Officially, it was part of the pediatric program. Unofficially, it operated with its own staff, its own budget, and its own clinical philosophy. The wing was known as the Neuropsychiatric Behavioral Unit. Internally, staff called it Ward C. Ward C did not treat all children. It treated a specific subset, those who did not respond to conventional behavioral interventions. Admission criteria included nonverbal behavior, aggression, sensory dysregulation, and persistent defiance. Many children were referred by family courts. Some came from schools. A few were surrendered by parents. Directly. Ward C did not view these children as patients. They were participants. The behavioral philosophy of the time emphasized compliance, not comfort. Doctors believed the primary barrier to rehabilitation was resistance. If resistance could be eliminated, function could be taught. If function could be taught, independence could be achieved. This belief shaped everything that followed. By 1979, Ward C had developed its own internal classification system. Children were assigned to categories based on responsiveness and compliance. Documentation from the period shows categories such as passive nonverbal, active nonverbal, verbal, defiant, sensory, regressive, aggression. These classifications predated standardized psychological diagnostic tools. They were functional, not clinical. They allowed staff to predict which children could be conditioned to follow orders and which could not. In 1981, the hospital received its first major foundation grant. The grant was not advertised publicly. It was issued by a private foundation based in Boston. The stated purpose was to study methods of behavioral compliance in nonverbal pediatric subjects. The hospital accepted. There were no hearings, no public oversight. No media announcements. Behavioral research was legal. Private grants were common. Few questioned the ethics of compliance-based programs at the time. Children in Ward C remained in the hospital full-time. They slept in shared rooms. They ate separately from other pediatric patients. They did not attend school. Education was not considered a priority. Compliance was. In 1983, the foundation renewed the grant. This time, funding expanded. Ward C hired new staff, purchased new equipment, and reallocated resources from other departments. Hospital administrators cooperated. Funding was funding. Few hospitals refused money in the 1980s. By 1985, Ward C had begun Phase 2. Phase 2 expanded the concept of compliance beyond observation. It introduced environmental conditioning. Children were placed in controlled settings designed to reduce sensory input and eliminate behavioral resistance. These environments were quiet, consistent, and repetitive. Schedules were strict. Movement was limited. Silence was preferred.